All right, we have come to the end of the week. So now we're going to start hitting into modes of ventilation. And the modes of ventilation, remember, we're going to do a slow entry into this so that we get more information spread out and we're not overtaxing ourselves. So, however, it's good to go and research more information so you get perspectives from different people and understanding from different thought processes. Don't overdo it because I want you to take it nice and slow so you can actually get that information and absorb it into your head and make it stick. On to the next slide. When you're picking a ventilator out for a patient, you want to pick out the one that is going to be best for that specific patient. I know that kind of sounds funny because it's information we might not have yet, but picking that ventilator out, if the patient needs, it's a pediatric patient, they need high frequency ventilation, well, then they need high frequency ventilation. If it's an adult and they need APRV, you need to have a ventilator that has APRV on it. We're going to get better and better at analyzing what the patient's needs are and then be able to pick the ventilator that would associate with that. As you get better in the field and you have more experience, you'll start to look at things like, well, I don't know, that LTV 1000 or 1200, the flow pattern is too quick for a pediatric patient. I wouldn't use that ventilator on that patient. And you start to become more and more proficient at understanding each and every ventilator and their modes of ventilation. All right, look at the big difference between the two of these ventilators. Now, both of those are the same company, so it's Servo, right? The Servo is owned by Maquette now, and the that Servo 900C is the one that I actually started on when I was a new grad at University of Rochester. It's an excellent vent. It's very durable. It has great qualities for the time frame that it was in. But if you look at those aircraft-looking dials that are on that, and there's a reason for that. A lot of the science that came out for ventilators was switched over from what the jet age when we went from rotorprop engines to jet engines, and we needed to have air sources to support our pilots. So then the thought process came from that and disseminated throughout history. But so now look at the Servo U and the digital access to it. That screen is amazing. You touch it and if you touch the mode, it'll actually give you a description of the mode and what the mode does. So it's a lot more user friendly. It's kind of built like an iPhone on the screen. As my daughter would say, Ermagerd. Those are some odd-looking ventilators, aren't they? Well, they're high-frequency ventilators. So there's a whole lot of things that we're going to get into down the road that's going to advance our thought process. That 3100A is a high-frequency oscillatory ventilator that supports neonatal ventilation when conventional ventilation is not cutting it. The one on the right is a jet ventilator made by Bonnell, and it's extremely efficient, effective high-frequency ventilator that has a lower mean airway pressure, so it causes a little bit less damage in some circumstances. So really cool stuff that we're going to be getting into. So I want you to be excited about what we're going to learn and also be patient. Factors in deciding what vent to use are going to vary throughout the hospital, but one of the big things that you need to remember is clinician familiarity, right? That's a hard word to say for some reason, but the more comfortable you are with a ventilator, the more you're going to learn and know about it. There may be modes in other ventilators that may suit your patients better that you have access to. So don't be one of the people that says, "Oh, I'm just going to use this one all the time, every time." Learn those other modes and those on the ventilators because that might actually do better for your patient. But the things that we're going to look at on those ventilators are what modes are available on those vents, pressure and flow capabilities. Some patients need a much higher flow or a higher pressure. One of our high frequency ventilators that we used that saved many, many lives didn't have the flow capacity for a pediatric patient, only neo patients, although I would have loved to have seen that in the pediatric population. Alarms and monitoring systems, is it a safe system? We're converting BiPAPs over to ventilators for the COVID problem that we have right now. And I'm helping University of Colorado work on that right now. And the danger with that is the limited alarms and monitoring that they're just not on there the way they would be on there for a conventional ventilator. So reliability is just the kind of ventilator that's going to fall apart. Some of the old ventilators they're pulling out of storage and putting into use, how reliable are those and are they going to fail on that patient? So we have to keep a good eye on those if we do choose to use those in the situation. And then cleanliness and functionality of equipment. Do not ever put a dirty ventilator on a patient. Make sure it's clean. I know that sounds like I shouldn't have to tell you that, but it's happened. So be very careful with that. Make sure you have good cleaning rituals, and the people that are taking care of your ventilators, if it's not you, are well. You might be thinking, why in the world is this guy repeating this stuff that he just said in the lecture earlier? Well, here's the thing. I have a rule with mechanical ventilation. You will hear me say everything important in this class 3 times at least, because I want it to sink into your head, and I'm going to go about it with different angles. So there is a method to the madness, and you will start to understand the reason why I'm discussing this. Unfortunately, you won't like me until after you've graduated and you're actually doing patient care and saving lives. So with that, the physiological goals of managing a patient would be to support and manipulate gas exchange. Well, that's our goal, right? We want to have good gas exchange so to meet metabolic needs, right? So that alveolar ventilation is what we're striving for. That's the true goal of ventilation, right? And then the goal of that is to maintain the arterial oxygenation and ventilation. So we're going to look at our PaO2 sat, CaO2, whatever, all that good stuff. And we're going to increase the expiratory lung volume. So, fuck. Let me guess what you're probably thinking. Isn't this something we just went over a little while ago? Absolutely. So one of my rules for mechanical ventilation, or anything that I'm trying to teach that is extremely important, is a rule of threes, that you hit that idea at least 3 times. That is going to penetrate that thick skull of yours and mine, and hopefully absorb the information a little bit better. And what I'll do with that information dissemination is I'll try to do it with a different angle. So for the people that may learn it one way, you'll kind of get it in a different direction, and it'll start to make a little bit more sense, hopefully. And then if it's not, always reach out, because these things are so important that we're talking about. That it's going to save a life one day. So our physiologic goals are to support and maintain gas exchange, right? Our main goal is to get that pH back to the patient's baseline, right? And CO2 and PO2, all because we want to get to the baseline by maintaining or manipulating alveolar ventilation. All right, and then we're going to be shooting for our oxygen status, and getting our lung volumes to a point where we're actually maintaining or improving the CO2 status as well. So manipulate the work of breathing. That's what we're doing, right? And then minimize cardiovascular impairment. We're going to get really in depth in that down the road. And then again, when you get to advanced mechanical ventilation, is not overdoing it. It's easy to throw a patient on a vent and put huge settings on there. We did that a long time ago, and we're the masters of giving patients ARDS and then impeding venous return and collapsing their cardiovascular system. So that's our goal, is to not do that, now that we learned how to mess somebody up. And then we want to make sure the patient is synchronous with the ventilator, which now with technology, it helps out a lot, but we are the masters of maintaining synchrony. But we have to make sure that we're spending a lot of time with our patients and assessing that. And then I just talked about the other stuff, but avoiding ventilation induced lung injury. Okay, a couple more goals. Keys to lung protection. Keeping our transpulmonary pressures below 27 centimeters of water pressure. And that's going to correspond well with our plateau pressure being under 28. Technically, it says under 30, but it says 30 question mark 28 is our goal. So 28 to 30 is where we want to kind of keep that plateau pressure. So then also a driving pressure of less than 15 centimeters of water pressure. What the heck is driving pressure? I've never heard of that before. I'm going to tell you. Driving pressure is the plateau airway pressure minus the PEEP. So that can be expressed as the ratio of lung volume to respiratory system compliance, which is kind of saying, hey, like if you take away that PEEP that is put on there by the RT and subtract that from the plateau pressure, that's actually what's driving that volume, right? So if, based on compliance and resistance. So here's your answer. Our tidal volume should vary from about 4 to 8 mLs per kilo of ideal body weight. Remember, 6 to 8 is for your normal patient, and then down to 4 with a restrictive lung disease process or ARDS. And a PEEP set to avoid de-recruitment for during exhalation. There's going to be a lot of cool things that we're going to show you how to do, like looking at lower inflection points on the graph and looking at doing lung opening procedures. Looking at different technologies, there's like 30 different names, of how to assess the ideal PEEP for your patient on advanced modes. So hold tight, we'll get there. Non-invasive ventilation. 75 to 80% of all patients receiving ventilatory assistance receive it invasively. So that's crazy, right? We want to make sure that we can decrease that number and get more patients on non-invasive. The more people that are on non-invasive that we can manage, the better off that patient's going to be, because we want to decrease ventilator-associated pneumonias, other infections. Remember, they get a line when they're intubated most of the time, or a lot of the times, and that could lead to invasive line infections, sepsis, all that other stuff that would lead to ARDS and death. So if we can avoid that, that's great. I can tell you, when we were doing being on transport, the amount of intubations that I ended up doing towards the end of my career was vastly lower than it was in the beginning of my career, because I realized, well, one, the technology for non-invasive accelerated, and then also our understanding of ventilation, of ventilator-associated pneumonia, um, grew dramatically as well. So we tried our best to keep the patient non-intubated and running on non-invasive ventilation. So when are we going to initiate a ventilator? Well, one, we have to look at the patient and say, are the indications present? Um, so I would sit there and look. My main things are, can the patient maintain their airway? Are they gurgling? Do they have a gag reflex? Are they able to cough? All those things, because if the patient can't maintain their airway, that's a number one reason to intubate, right? If they're not breathing at all, they have no generation of ventilation, they should be intubated because they probably can't support themselves either. If they vomited, they would aspirate. So that's the thing with non-invasive ventilation. We want to avoid aspiration as well because that's going to lead to the same problem that we would have with an increase of ventilator-associated pneumonia. We're going to have an infection. We don't want to have an infection. So then we're going to look at the type of method to establish an airway. Sometimes our out in the field, we'll have people do an LMA or any subglottic airways. Those are great. They work just fine. Now, you'd probably want to have a secured airway, an endotracheal tube when you got to the hospital, but we can ventilate patients just fine with a subglottic airway. Then we're going to start to look at things like pressure or volume ventilation, and that I'm telling you, like people make such a big deal of it. It's usually facility dependent, practitioner dependent, physician dependent. On what type of mode that your pressure or volume mode that you're going to use. And then are we going to take over all ventilation? Is the patient so sick that we need to maintain absolutely everything for them, or can we let them continue to ventilate on their own? Then the mode of ventilation, again, that's probably going to be somewhat physician or practitioner preference, and then we're going to select the appropriate settings for that patient, and then select the appropriate alarms and backup alarms for the patient as well. So here's a very important thing I want you guys to be able to understand and do as students or respiratory therapists is to be able to separate the two of these thought processes. Notice if you're looking at the modes on there, both sides, there's a separation, delineation down the middle between volume and pressure. Remember, volume modes are going to be given, like you set a volume and that volume is delivered. Pressure modes are you set a pressure and that pressure is delivered. You can have assist control volume or assist control with pressure as the delivery system. Same thing with SIMV. Same thing with so they're just two different delivery options. Okay, so stop fighting it. Relax. Absorb the information. Volume delivery, assist control, or pressure delivery, pressure control. Volume delivery, SIMV, or pressure delivery, SIMV. We're going to get a little more into that here. So how does the patient actually control the mode, right? If the patient's in control, how do they actually do that? Well, they're triggering it at either a negative pressure, a negative flow, a time cycle, but we'll talk about all that stuff down the road, and then neurally adjusted, right? So it's a reading on a millivolt, and in Servo's case, it's a trigger that is an electronic trigger created by the human body. It's the diaphragm triggering through the phrenic nerve that's being sensed. So good stuff. You're going to hear this a million times from me in this class. Ventilators will go about things with different languages. That's just how they work. The companies have different names for different types of modes. They'll be very similar when you think of PRVC, auto flow, all those things. They're very similar, yet the name behind it is copyright or a trademarked, right? So they can't call somebody else's mode their mode. You have to have a different name, and that stinks for the people trying to learn it, but that's just how life is. So you may hear me say, well, in this case, this mode would be, in this ventilator, this mode would be called this. That's so. It's just how it is, and that's something we have to get used to. The ultimate control. This is something for physicians and respiratory therapy only. Ultimate control modes. Read on. Okay, controlled ventilation. True controlled ventilation, the patient can't trigger the ventilator at all. So the idea of that is they're supposed to be paralyzed, sedated, not moving, and we control absolutely everything about that patient. So they should not be able to trigger at all. They shouldn't be able to do anything. They should just be laying there, enjoying their surgery. So the advantage of that is going to eliminate all work of breathing. The muscles can relax and not have any work whatsoever. Now there are downfalls to that, right? Because the more we give, more paralytics and sedation we give, the longer the patient is going to be on the ventilator. So we have to be really thoughtful on that. The other advantage would be total control allows us to use an inverse ratio. If the patient's paralyzed and sedated, they don't know that it's a ridiculously uncomfortable mode of ventilation, but we can oxygenate and oxygenate better in an inverse mode. And we'll talk a whole ton about that. Assist control. So the assist control can be delivered in a volume target or pressure target. Remember, we just talked about that, right? Assist control pressure or assist control volume, right? So if the patient is in volume or pressure, right, we set their I time, rate, FiO2, their PEEP, everything. We set everything for them. But the big difference is this patient can now take another breath if they want to. If their body is telling them that they need to breathe a little bit more, they can actually breathe a little bit more. But what do they get? Well, if I set a tidal volume of 500, every single time that patient takes a breath, they're going to get a tidal volume of 500. So this could be beneficial, but it also could be a problem because that patient may overdo it on themselves. If it's anxiety that's triggering the breath, they can blow off all their CO2 and mess up their pH pretty bad and become extremely alkalotic. We don't want to have that. So again, you have to keep a good eye on your patients at all times. So the beauty of assist control ventilation, it's going to ensure minimum safe levels of ventilation. And the patient can increase their rate to get a larger minute ventilation. Remember, the volume is going to stay the same. They can, but minute ventilation is volume times rate over a minute. So if the patient's breathing more, it'll improve their minute ventilation, right? So disadvantages, an increase of work of breathing, if not applied properly. That's any ventilator, right? Any mode, if you do it wrong, it's going to make it worse, right? So advantages, assist control, or pressure, volume, or pressure include variable flow. Oh shit. Alrighty. So a little bit more about our assist control. Some advantages of assist control ventilation include ensured minimum safe levels of ventilation. The patient can increase that ventilation if they want by increasing their rate. So their minute ventilation will go up. Remember, our minute ventilation is just respiratory rate times tidal volume. The tidal volume will be consistent. Say we set it at 500 and a rate of 10, they should be at 5 for 5 liters for minute ventilation. But if their rate goes up to 20, now it's 10-liter minute ventilation. So the patient's able to control that. They can't go under, but they can go over if they'd want to, right? With any ventilator mode, if you do it improperly, you can increase the work of breathing. The patient will find it difficult, right? And they'll become anxious and they'll have all kinds of problems. So make sure that you're assessing your patient consistently. So advantages of assist control pressure ventilation would be variable flow, ensures plateau pressures are controlled. The inspiratory pressures will stay the same every time that patient takes a breath. So we won't have these big spikes in pressure, right? And then improved gas distribution. So why would that be? We're going to talk a whole bunch about this. When you look at the actual flow pattern, the patient gets to their peak inspiratory pressure or their pressure control breath, and then it's going to hold that pressure in there until the inspiratory cycle is done. So you'll have a longer, sustained interaction of oxygen in touching the alveoli, so it's just a longer time. So then we can also have high mean airway pressures and tidal volume variations if you're in pressure, right? And then if you're in volume, we would have pressure variations. So then hypoventilation acidosis. So you got to be careful. Just keep an eye on your patient. Here's a really funny thing. When I first started at Pima, they said you're going to be teaching IMV. It's going to be 6 weeks. I'm like, how can I teach one mode of ventilation for 6 weeks? Well, they just labeled it differently. Intermittent mandatory ventilation. This mode is not really used very much at all anymore. And I'm going to tell you why. Intermittent mandatory ventilation may be used by means of providing partial or full ventilatory support. So the volume or the pressure in the ventilation is going to be delivered. All right, and what happens though is the patient, if they want to increase their breath, increase their rate, they can. But the problem is the ventilator doesn't sense that. The ventilator doesn't see that they're taking a breath. So say back in the day when we used this, we were using 12 to 15 milliliters per kilogram, huge volumes, right? Now say the patient was set at a rate of 10, and every 6 seconds they were getting a breath. Well, let's just say that the patient at 5.5 seconds decided to take their breath, or 5 seconds decided to take their breath on their own. So they take a breath, which might be 5 mLs per kilo, and then the ventilator cycles and gives them another 15 mLs per kilo. Now they're hitting 20 mLs per kilo. It didn't know that they were taking a breath. It didn't understand that, so it was able to cycle on top of their breath. So this would be a pneumothorax mode of ventilation, if you want to think of it that way. So this is the reason why we don't use it. It doesn't know what it doesn't see what the patient is doing. So IMV wasn't working quite right. So what did we do? We taught the ventilator. I didn't do it. I wish I would have. I'd be rich. But they gave technology to the ventilator to be able to understand what it was that the patient was doing. Introduced in 1975. Lots of good things happened in 1975. It was synchronized so that the ventilator would not give a breath when the patient was in the middle of their breath. So it stops the ventilator from stepping on the patient's breath. So look at the diagram, you could see. So do you remember when I said people who have to have things concrete will have difficulties with mechanical ventilation? And here's one of the reasons why. Not all the calculations are going to look the same. I know that these calculations look different than maybe the other calculations you have in your book or the calculations that I gave you on that paper in day 1. There's calculations on there. Make sure you look at those. When you're looking at those calculations, there may be variability. Guess what? That's okay because they fall into the category where they're all acceptable. So don't overdo it. Don't overthink it. It's okay. When you go to take your exam and you utilize those calculations, the measure of error will be accounted for with the variables in calculations. So it doesn't matter which one you're using as long as it's reasonable. Obviously, the one that we'd probably use would be the ARDSNet ideal body weight one. But you may have variations and the ones, it's okay. You'll be fine, I promise. Pressure support breaths. Well, this is important stuff. Why? Because we're allowing the patient to do what they want to do when they want to do it with a little bit of help. So The pressure support is going to assist the patient's spontaneous breath by giving a centimeter of water pressure. What the patient's able to trigger the ventilator, and then we're giving them extra pressure. So what does extra pressure give? Well, it gives a larger volume, right? So the patient on their own triggers the ventilator with a negative flow, negative pressure, or electronic stimulus. And when they do that, the ventilator is going to give that extra pressure on top of whatever they're able to generate. That's good stuff, right? Increasing the minute ventilation, which will help to maintain the patient's alveolar ventilation, which will improve their blood gas. Ooh, I love how it all goes all so smoothly. Okay, one of the things I didn't mention on the last slide that I can mention on this slide because I see it and it triggers my memory. Trigger. Pressure support is designed to overcome the resistance of the ET tube. That is the initial design of pressure support, to overcome the resistance of the ET tube. So remember, we're putting a ET tube down the patient's throat, which is decreasing their foramen size, which increases their resistance. So now we need to fix what it is that we broke, right? And so we give them pressure support, but then we started utilizing pressure support when higher pressures to be able to maintain the patient's minute ventilation to support their pH in the most comfortable possible way. If the patient's able to trigger, they're able to control their I time, they're going to control their expiratory time, then the patient is going to be much more comfortable. I know there's a lot of complaints about having to do this online and not in the classroom, but you know what? You can literally be having a snack while you're watching this, drinking a soda or whatever it is that you drink. I'm not saying whiskey or anything. That's probably inappropriate. But you can actually have those things and I won't even yell at you because I can't see you. Be professional. What does Egan say? That's a good question, right? So, with tidal volume and a respiratory rate or minute ventilation, in modern practice, we're using 4 to 8 milliliters per kilogram of ideal body weight. The Now the recommendation now is 6 to 8 milliliters per kilogram of ideal body weight with a rate of 12 to 16 breaths per minute. Now we can go down to 4 milliliters per kilogram for patients with ARDS or acute lung injury. So after the initiation of ventilation, if we put that patient on say 8 mLs per kilo and their plateau pressure is 31, well, we can now decrease that down to 6 mLs per kilo and see where that goes. Are we in an acceptable range, and is our blood gas acceptable? Okay, trigger sensitivity. We're going to set that to the least possible setting without auto triggering. So you think it would make a lot of sense to decrease that sensitivity to make it super easy. Well, you do, right? But if the ventilator is auto cycling, that means as it gives a breath, as soon as that breath exhales, it's going to expand the lungs and the lungs contract. And when they contract, back down or release, there's going to be a small little recoil at the end. That can create an auto trigger. Very easy to replicate this with a test lung because some of the test lungs have a high resistance on them, and when they slam shut, there's a vibration at the end, and that will cycle the breath again. So we want to make sure that we're not auto cycling the ventilator. Because what's going to happen with that will blow off all their CO2 and they'll become extremely alkalotic. So we have to manage that well. So we like to set the flow trigger to usually about 1 to 2 liters per minute in a flow sensitivity, and then again 1 to 2 centimeters below the PEEP for if you're doing a pressure trigger. All right, so remember, I'm giving you this information, but we actually have lectures that are completely on these things, like ideal eye time, peak flow, all that other good stuff. Then we're going to calculate everything out and try to make it make all sense, right? The goal for this is to have repetition and little doses of the information throughout the lectures, so you get a taste of it. Your mind wants to absorb more, but you don't let it, so that it will take that information, and then we'll hit you with a whole bunch of different teasers and then give you the full amount of information. So there is a method to the madness. Be very patient with it. Eye time, we're going to set that. It's usually going to be about 0.6 to 1.0 for a normal adult. Well, oh geez Louise, that 0.6 is pretty low. We're pretty close to 1 second eye time for an adult. Which would result in an eye to E ratio of about 1 to 2 for a normal rate with a normal healthy individual. This is going to correspond to an initial peak flow setting of approximately about 60 liters per minute. So if you remember 60 liters per minute, that's 1 liter per second. This will help you to remember what settings to start on when you're doing an initial setup. Right, you're going to see on the ventilator there's going to be a button that says inspiratory pause, right? So inspiratory pause is a little bit different than an inspiratory hold. An inspiratory hold will give you a plateau pressure. An inspiratory pause will allow for better distribution of oxygenation, right? The longer you're in an inspiratory phase, the longer you're going to have a higher pressure, which is allowing for a better gas exchange with the alveoli, because the alveoli are more distended and they become closer to the capillary vessel as it's going by. So it does have a purpose. It's not utilized as often as you might think. PEEP and CPAP. Initially, PEEP is set at about 5 centimeters of water pressure, and the reason for that, as an adult, we're about 3 to 5 centimeters of water pressure for intrinsic. We have this lovely thing called an epiglottis that allows us to generate PEEP within our airway, or maintain PEEP within our airway. We end up using higher PEEPs to improve or maintain FRC and oxygenation. If I was doing a test, I would put that very specific thing on there. Higher PEEPs would do what? Improve or maintain FRC and oxygenation. In high FRC conditions, it may be used to offset auto PEEP. So what we'll do with auto PEEP, this is going to be on my whole trigger lecture down the road, but we're going to increase the PEEP to meet the intrinsic PEEP. And the reason for that, it allows the patient to be able to trigger the ventilator. They can't trigger the ventilator very easily if they have a very high intrinsic PEEP, because the trigger would be so much lower. So it makes it really difficult for it to work. So we're going to talk all about that. Make sure you understand that. Again, we're going to have a whole lecture on alarms as well. However, the things that you want to know now about alarms is you will have nightmares with you hearing alarms in your sleep. This is your body kind of getting used to the stress of the situations that you're getting into. Those alarms should be responded to regularly. The majority of alarms go off and they're false alarms, but that shouldn't be the thing that kind of keeps you from responding to them. You should be responding to all alarms that are going off and adjust the alarms to appropriate settings so they don't go off all the time. And like I was just saying, on average, ICU alarms occur 6 times per hour per room. That is a lot of alarms going off, and that's the reason why we have side effects from it as practitioners, where we hear these alarms going off all the time. 44% of are false positive alarms. That's pretty significant, right? And those alarms, however, are there to protect the patient, so set them accordingly. That's your job. Do your job, man.